almost all age groups. It's very important to sort of know the mechanism of the various tachycardias based on the ECG, because not only it decides the immediate therapy, but also how we are going to treat these patients in long term. Let us now look at a few, introductory remarks about this and the definition. We call a person as having a narrow QRS tachycardia when the ventricular rate is more than 100 beats per minute and the QRS duration is less than 120 milliseconds. Here I would like to pause a little bit. It is always, I see young people making a default diagnosis of narrow QRS tachycardia on the 12-lead ECG based on the narrowest QRS complex in all the 12 leads. So for you to call it as a narrow QRS tachycardia, you should look at all the 12 leads and see that the widest, the broadest QRS should be less than 120 milliseconds. So it is very important because many a times it is misclassified looking at the narrowest QRS complex. It usually indicates a supraventricular tachycardia, and this tachycardia originates above the AV node or includes the AV node as a part of the circuit. Now, it is the QRS complex is basically narrow because the electrical impulse travels down the efficient His-Purkinje system for antegrade conduction of the ventricular myocardium. We should realize that the muscle-to-muscle conduction is very inefficient and gives rise to broad QRS complex, and His-Purkinje system is a very efficient conductor of electrical impulse, and that's what gives rise to the narrow QRS complex. However, occasionally, when you have an aberrant conduction or if there is an underlying bundle branch block, the QRS complex can still be broad, and these are classified as broad complex tachycardia even though they are supraventricular tachycardias. These narrow QRS complex tachycardias can either be paroxysmal or they can be incessant, meaning that they can persist for most of the part of the 24 hours. Now, one may ask, what is the importance? It is narrow QRS tachycardia, we'll all bunch them together. It is one simple looking tachycardia, but it's important for us to recognize the various types of tachycardia because that decides the therapy, as I told you, both acute as well as chronic. Not only is it important for us to understand the mechanism of the tachycardia, it also depends on the immediate and long-term therapy. So it is very important for us to understand what is the mechanism based on the ECG. We can classify narrow QRS tachycardias in two ways. One, based on the ECG as short RP tachycardia and a long RP tachycardia, which I will come to you subsequently. Then we can classify them based on the mechanism. Either that they are dependent on the AV node, that is, AV node is a part of the circuit, and what it implies is if you block the AV node temporarily, then you are terminating the tachycardia. Then there are certain narrow QRS tachycardias which are AV node independent. Here, if you block the AV node, the tachycardia persists in the atrium, only the ventricular rate slows down. So it's important for us to understand these two mechanisms. Now, how do we approach this narrow QRS tachycardia? We have to ask ourselves a few questions. One, is the tachycardia, does the tachycardia have truly a narrow QRS complex? The second question is it regular or irregular? If it is regular, is it a short RP tachycardia or a long RP tachycardia? And finally, what is the response to carotid sinus massage or adenosine? There are different types of supraventricular tachycardias which can give rise to narrow QRS tachycardias, the most common being the AV node reentry tachycardia. Here the reentry circuit is within the AV node. The second is the AV reentry tachycardia. These are variants of WPW. These are accessory pathway mediated tachycardias. And the third is atrial flutter and fibrillation. In regular tachycardias, it's usually atrial flutter. However, occasionally in rapid rates, atrial fibrillation may appear regular if you're not careful to caliparize the RR complexes. Sinus tachycardia and atrial tachycardias can also give rise to narrow QRS tachycardias. Now, when we look at the ECG, so let us see how we approach it on the ECG. When we look at a tachycardia, we should look at the tachycardia, drop an imaginary line in between the two RR complexes. If you have the P wave coming in the first 50% or the first half of the RR complexes, then it is a short RP tachycardia. Now if you have the P wave appearing on the second half, then it is called as the long RP tachycardia. We'll go into this further in a little while, and now there are two different types of short RP tachycardia. In the first variety, the P wave is buried within the QRS complex, or it is just immediately adjacent to the preceding QRS, and this is typically seen with typical slow fast AV node reentry tachycardia. The other differential diagnosis being a very rare tachycardia called the junctional ectopic tachycardia. However, the most common one is the typical slow fast AV node reentry tachycardia. This is a 27-year-old female with palpitation, and what you can see here, if you look at it very carefully, is during normal sinus rhythm, this is a P wave followed by QRS complex. However, during tachycardia, you can see a small R prime appearing there. This is the P wave, which is just adjacent to the QRS complex, and this is a short RP tachycardia, the type 1 short RP tachycardia, where you have the P wave appearing just immediately after the QRS complex. Now this is usually because of so-called AV node reentry tachycardia. Here the fast pathway comes here and the slow pathway comes near the ostium of the coronary sinus. The reentry circuit is entirely within the central part of the heart. The activation of the atrium and ventricle occurs almost near simultaneously. So that is why approximately in 50% of the people, the P wave is buried within the QRS complex. In about 45% of people, the P waves can appear just at the tail end of the QRS complex, giving rise to a pseudo S in lead 2-3 AVF and a R prime in lead V1. In about 5%, the P waves can appear just before the QRS complex without a PR interval, and this can also be seen very rarely. Now this is one example where you can see, as you can see, there's a tachycardia going on, and you can see a broad S wave here. Even though there is a narrow S wave here, once the tachycardia terminates, you can see the fat S wave becomes much more narrow here. This indicates that there is a P wave hidden within this latter half of the QRS complex, giving rise to this fat S wave. This is very typical of an AV node reentry tachycardia. If you pick this up, you're almost sure that you're dealing with a AV node reentry tachycardia. The rare variant being in electrophysiology circles, we discuss about the septal accessory pathways, which will not confuse you with, but nevertheless, if you pick this up, it is quite likely that you're dealing with AV node reentry tachycardia. The second short RP tachycardia is one where the P wave is slightly away from the QRS complex on the ST segment. The most common cause is AV reentry tachycardia. These are basically accessory pathways which traverse the mitral or the tricuspid annulus. These are myocardial fibers which traverse the atrial and, the mitral and tricuspid annulus and connect the atrium to the ventricle, and this can give rise to tachycardia, something which is similar to this. What one can observe if one looks at it this tachycardia very carefully is, one is it's very fast. The second is, if this tachycardia gives rise to a very rapid tachycardia, and this is because of a reentry circuit which is due to an eccentric activation. So the P wave is because of the inscription which occurs eccentrically, and it takes some time to go away from the QRS complex, giving rise to an P wave inscription on the ST segment. If you look at this ST segment very carefully in this patient, you can see that the P wave is on the ST segment away from the QRS complex, and the time duration from the end or from the QRS complex to the P wave is approximately 2 small squares here. Usually it's about more than 70 milliseconds is what we get in a AV reentry tachycardia. The other thing which can happen in patients with AV reentry tachycardia is what we call as a QRS alternance. This usually indicates, though it can be seen in other tachycardias, but if you see a typical QRS alternance like that happening, then it also indicates an AV reentry tachycardia. So there are two clues for you to pick up an AV reentry tachycardia. One is a P wave which is on the ST segment away from the QRS complex, but nevertheless in the first half of the imaginary line which you have drawn between two RR complexes. Second is the QRS alternance, which you can, if you can identify, then again it gives you a clue that you are dealing with an accessory pathway mediated tachycardia. Let us now look at the long RP tachycardias. Now we draw, as I told you, we draw a line, drop a line between two QRS complexes, and if you have a P wave which comes on the second half, then we call this as a long RP tachycardia. The most common one being sinus tachycardia, but we should also not forget to look for atrial tachycardia. The other tachycardia which can be seen occasionally are atypical AV node reentry tachycardia, where instead of fast AV reentry tachycardia, it is a fast slow, which is a reversal of activation sequence within the AV node, which can give rise to a P wave which comes on the second half of the QRS complex. Now, the third one, which is very rare, is what is called as a permanent junctional reciprocating tachycardia. Let us look at some of the examples of these tachycardia so that you can identify them. This is a sinus tachycardia. This you can see is again a long RP tachycardia where you can see the P wave in the second half, and the third one is an atypical AV-NRT / PGRT. Let us go and see how we differentiate this. Now, this is a common scenario which you are likely to be faced with, a 20-year-old female with palpitation. You can look at it and see that the patient has got tachycardia, heart rate of more than 100 beats per minute. It's narrow QRS complex, and what one can see is there's a P wave in the second half of the RR, the imaginary line you draw, and it's in the second half of the imaginary line, and then what one can observe is that the P wave in lead 2 is taller than in lead 1. So it's a very important identity. The second thing is lead AVR has got a negative P wave. The third is there's a positive negative deflection in lead V1. So all three should be there for you to call this a sinus tachycardia. So one of the differential diagnoses is what is called a sinoatrial reentry tachycardia, but that's an extremely rare phenomena, so you need not be worried about it, but this usually indicates a sinus tachycardia. Now, sinus tachycardia, as you know, the activation force goes from the superior part of the right atrium towards the left leg, so the axis is typically 60 degrees, giving rise to a tall P wave, upright P wave in lead 2. So I always tell my fellows that you should look at lead 1 and lead 2. The lead 2 P wave should be taller than in lead 1, and both of them should be upright, and lead AVR should be inverted, and lead V1 should have a biphasic P wave for you to call it a sinus rhythm or sinus tachycardia. This is another ECG. Again, you can see that the patient has got narrow QRS tachycardia. If you look at it very carefully, there is a P wave just preceding the QRS complex. If we drop an imaginary line in between, we know now that this is a long RP tachycardia. Now, looking at it carefully, we'll see that the P waves are inverted in 2, 3, and AVF, meaning that the atrium is activated from below upwards. Now, this indicates that it's an ectopic atrial rhythm, and this is an atrial tachycardia. Now, how can we make out it's an atrial tachycardia? One is the other differential diagnosis can be an atypical AV node reentry tachycardia. It could also be paroxysmal, permanent junctional reciprocating tachycardia. So one of the maneuvers we should consider doing is either to give a carotid massage or give adenosine. So when we give adenosine, you can see that the P waves continue in the upper chamber, that is in the atrium, while the ventricular rate slows down. Here you can see in between the two P waves, there is an isoelectric line indicating that it is not an atrial flutter. but this is an atrial tachycardia. In an atrial flutter, there is a continuous undulation of the baseline giving rise to flutter waves. However, in an atrial tachycardia, there is an isoelectric line in between the two P waves. So this is an AV node independent tachycardia. In this tachycardia, you may not be able to terminate the tachycardia by giving adenosine, diltiazem, or beta blockers or digoxin. However, you may be able to get a rate control. For termination of this tachycardia, you might require a class 3 agent or drugs like class flecainide or propafenone to bring this tachycardia to sinus rhythm. Let us look at another tachycardia, a 35-year-old male with incessant palpitation and has developed left ventricular dysfunction. Any tachycardia which is incessant, either atrial tachycardia, atrial fibrillation, atrial flutter, or some of these tachycardias can give rise to what is known as a tachycardiomyopathy. Now here, if you look at this ECG very carefully, you will see again that this is a tachycardia. You drop a line, this is a long RP tachycardia. However, the P waves are again inverted in lead 2, 3, and AVF. You can see that the lead P wave is upright in lead AVR, and it is sort of upright in lead V1. So this could be the differential diagnosis, again boils down to atrial tachycardia from the low right atrium or low left atrium. It could be it cannot be an atrial flutter because there is no flutter waves which you can see. It could be an atypical AV node reentry tachycardia, meaning that this is going through the slow pathway and coming up the fast pathway, and it could be a permanent junctional reciprocating tachycardia. One of the ways to identify this is to give adenosine. When we give adenosine, you will see that the tachycardia terminates. This is a P wave, which is a sinus P wave. This is followed by a QRS complex, and then you can see an inverted P wave. So what has happened is this QRS complex, after this QRS complex, the impulse has gone through the accessory pathway again and then inscribed another QRS complex there. Then the tachycardia terminates for a few beats. Then slowly again it restarts again, and this is what is called as a permanent junctional reciprocating tachycardia. This is one of the variants of pre-excitation. It's a slowly conducting retrograde pathway. It can give rise to severe left ventricular dysfunction. Many a times it is mistaken for cardiomyopathies. We should identify this because if you identify this tachycardia, this is very amenable to radiofrequency catheter ablation. Drugs usually has no effect on this tachycardia other than slowing the rate and making it more incessant. So it is very important. So if you give adenosine, it terminates for a few beats and then restarts again and continues with the same morphology of P wave as we go along. And you can compare this with the previous ECGs which I have shown, where when you have an atrial tachycardia, you give adenosine, the tachycardia continues. While this is an AV node dependent tachycardia, the atrial tachycardia was an AV node independent tachycardia. Another tachycardia which can be seen commonly, especially in the post-operative settings and in patients who have undergone cardiac surgery or patients who have COPD, is atrial flutter. Here you can see the flutter waves which are like sawtooth waves in the inferior leads. And it is important to recognize this. The ventricular rate is usually half the atrial rates, and the ventricular rate is usually 140 to 150 beats per minute. So whenever you walk into a setting of an emergency room, you see a patient having a regular tachycardia, approximately about 150 beats per minute. Look carefully at the inferior leads. You will be able to pick up these flutter waves with 2:1 conduction, giving rise to a very regular tachycardia, and it is not to be missed. Here the tachycardia is going on in the upper chamber, just like this. So the tachycardia is around the tricuspid annulus usually, giving rise to a atrial flutter, and every second beat is conducted down into the ventricles, giving rise to this sort of mechanism. And if you block the AV node, here the tachycardia continues in the atrium while you can slow down the ventricular rate. However, the control of ventricular rate in atrial flutter is slightly more difficult than in atrial fibrillation because there is no concealed conduction. So let us look at what are the regular narrow QRS tachycardia. One is the short RP tachycardia, which is AVNRT, AVRT, and junctional ectopic tachycardia, which is very rare. The long RP tachycardias are sinus tachycardia, atrial tachycardia, atypical AV node reentry tachycardia, and permanent junctional reciprocating tachycardias. Atrial flutter with 2:1 conduction can also give rise to a regular narrow QRS tachycardia. While these two tachycardia, sinus tachycardia, atrial tachycardias, atrial flutter are AV node independent tachycardias. The rest of them are AV node dependent tachycardias. So anything which you give, except jet, anything which you give to block the AV node temporarily will terminate the tachycardia, while as in these AV node independent tachycardias, you can only get a ventricular rate control. When we look at irregular narrow QRS tachycardia, we're looking at few things. One is, the most common one is atrial fibrillation. The second is atrial tachycardia with varying conduction. And the third is atrial flutter with varying conduction. I'll show you some of the ECGs which will help you to identify this. This is no brainer, anybody can recognize this, we should recognize this. This is atrial fibrillation, narrow QRS tachycardia, irregularly irregular. But if you see very quickly, you may mistake it for a regular tachycardia, but you should always take a piece of paper and caliperize the QRS complexes to see that they are regular. It's very important for youngsters to do this so that you can identify the minor R to R variations. Another tachycardia which can be seen is this. This is a short bursts of atrial tachycardia followed by periods of sinus rhythm. This is not tachybrady syndrome. Many a times I'm sent these ECGs by people saying that this is tachybrady syndrome. This is not tachybrady syndrome. What is happening here is there is a burst of tachycardia followed by termination of the tachycardia. This is an automaticity. There is a gradual warm up and a cool down phenomena followed by termination. This indicates that the mechanism of tachycardia is automaticity, and this is not tachybrady syndrome. In tachybrady syndrome, what happens is there is a tachycardia and it is followed by a long pause. Whereas here, there is a tachycardia followed by resumption of sinus rhythm with short intermittent bursts of atrial tachycardia. Another tachycardia which can also be irregular is atrial flutter. Again, you can see the flutter waves, which is sawtooth-like waves in the inferior leads. And atrial flutter with varying conduction can be at various conduction. It can get 3:1 conduction, 4:1 conduction. You can have varying conduction. In conclusion, narrow QRS tachycardia is due to supraventricular tachycardias, and it is a rather common condition and afflicts young people. It has varied causes, and ECGs gives you very important clues for you to identify the mechanism of tachycardia. And it's very important for you to identify the type of tachycardia because you can decide about the acute and the long-term therapy in these patients so that you can help these patients and prevent their morbidity. There is no mortality in most of this unless they develop left ventricular dysfunction, but most of them have, they're quite symptomatic because of the recurrent episodes. Thank you all for a patient hearing.
That was an excellent presentation, and very frequently